Hi, I'm Beatrice and PhD. What used to be that time of the month is now this time of the month. Welcome to our community, a curated space for everyone going through perimenopause and menopause. A place where we can find support, good laughs, great tips on products, and lots of education on health. There's beauty in aging. Whatever beautiful means to you, this time of the month will help you find it and live it. The content expressed in this time of the month is not intended to be a substitute for medical advice. The views and opinions expressed on this show are those of the speakers. And I'm so excited because today we're going to sit on the couch with Dr. Jessica Green. She's an obstetrician gynecologist, and we're going to talk about just the definitions around menopause, understand our hormones, how they work, why they work, and what that means through our changing cycles, and just our health as women through 30s, 40s, 50s, and beyond. So welcome.
Thank you so much. It's exciting.
So Dr. Green, in addition to being a very busy OBGYN, you are a mother of?
3 boys.
3 boys.
Yeah, naturally. I would just have boys being a gynecologist.
So that keeps you busy too?
Yeah, really busy. Yeah.
So obviously that must really be interesting to juggle. Delivering babies at all times of day or night.
Yeah, if I'm on call, absolutely.
And how old are your children? How spaced apart?
I have a 2-year-old, a 4.5-year-old, and a 7.5-year-old. Yeah.
Keeps things interesting.
And a 42-year-old.
Oh, you mean your partner. Yes.
Yeah.
So basically, like many of us, you're just running around and trying to...
Yeah. I usually make the joke that if I just tilt my head up that I can like still breathe. I can just like meet the surface of the water and not drown. But yeah, I think we're all living like that. It is a lot of fun though. And I like being busy, so.
Well, busy is a good starting point for, many of us, our journey. We're busy raising children.
Yeah.
And if we have children, just busy in life.
Yeah.
And you're barreling through life and all of a sudden, we tilt our head up and realize, wait, something's going on with my body. So let's start there. Just the definitions. What is menopause? And can you talk about words like menopause, menopause, and what is even post-menopause?
Yeah. I think it's a really good question, and I have to clarify this honestly every single day when I see people in my office. So perimenopause refers to the number of years that lead up to your final menstrual period. And it's interesting because the term menopause as well as postmenopause can almost be used interchangeably. If we're talking about menopause, like the moment that you become postmenopause, it's impossible to know at the time that it's happening because your final menstrual period is a retrospective diagnosis. So you don't know that you're post-menopause until you've had 1 year without periods that hasn't been induced by surgery or medication. So you're going through life and all of a sudden you notice that your periods become chaotic, as well as a lot of other symptoms that we can talk about. And you're right in alluding to the fact that this is happening at a time when we are so busy. If you're the sandwich generation, you're also looking after your
dependents,
your parents. You're looking after your aging parents as well as young children at the same time, and you're probably approaching your, peak productivity and careers going well, and all of a sudden all these things are happening that feel really out of your control and affect you deeply in terms of your quality of life. So perimenopause can be even up to like 10 years before your final menstrual period. And it's really hard to know when that's going to happen. So then you have a year without any bleeding. Now you are post-menopause, and that defines the time in your life when your ovaries are now no longer active. And that is to mean that you're not releasing an egg or ovulating.
And that really is rest of life, right? I mean, it's just the last stage of our reproductive lifespan, not in a negative way.
Yeah. And I like to point out that actually we as women are so productive and healthy and living so long that menopause or post-menopause is really up to a third of our life, right? So many of us will spend arguably more time post-menopause than we will even in our reproductive life. Like, you know, we're living, some of us, until we're 90.
Yeah.
So it's a time in our life where we want to optimize health outcomes, optimize quality of life so that we continue to be our best selves.
That's so important, because I don't know if people realize it, that
Yeah.
it's, as you said, 1/3 to pushing even
More than
40% as
Yeah.
we age.
Yeah.
And we want to feel
Yeah.
healthy, productive. So that's
Yeah.
why we're just going to try to debunk some myths. You know,
Sure.
you mentioned the fact that, oh, it feels out of our control, and it's certainly, there's an element of it. But before we get to what we can control, just explain a little bit more what's happening in that, some of the symptoms in the perimenopause.
Right. So from a physiology perspective, what's happening is that your ovaries are aging, right? So, and that's no surprise. We all, I think, have a grasp of that. But what that means is that your brain is sending messages to your ovary. Your ovary is now not as attentive. It is becoming hard of hearing, is what I tell some people. So your brain used to just have to talk to your ovary to develop a follicle and release an egg every month. Now your brain is like screaming at your ovaries. So you get an increase in hormones in your 40s before you then, later on, after menopause, have a decrease in your hormones. So that actually is why a lot of women will come to see a gynecologist in their 40s, because suddenly their periods, which have never been a problem in their lives, are becoming one. So it's true that you know, your brain is sending lots of FSH, so follicular stimulating hormone, to your ovaries. Your ovaries are actually producing more estrogen than they would have years prior, and having a tougher time getting to the point of releasing an egg, which we call ovulation. And something happens that's really critical after ovulation. Estrogen then takes a bit of a backseat, and you get a rise in this other hormone called progesterone. And every woman on this earth, for the most part, we're all very different in many ways, but we have one thing in common, which is after we release an egg, we get roughly a rise in progesterone for 14 days. And then if we have not conceived, we haven't gotten pregnant, you'll get a drop in the progesterone. And that is your body's signal to shed the lining of the uterus and have a period. So then if we never get to the point of ovulating, we now enter this phase, we call it as gynecologists an anovulatory cycle, where you just get this prolonged exposure to estrogen. You never get the release of the egg, the rise of progesterone, and the proper signal to shed the lining of the uterus. You run into really difficult, challenging bleeding, which can often be associated with pain. It can land women in the emergency department for even blood transfusions, because now your uterus is just having this discoordinated shedding of the lining. It's not doing it efficiently. You're bleeding for longer, heavier, and more frequently. So one of the first things that women may experience in perimenopause is a disruption in their menses.
So that's a first sign.
Yeah, that's one of. Certainly, I've met women who will experience hot flashes, which we can talk a lot about. So daytime hot flashes or nighttime hot flashes first, before there's any disruption. And women also may...
As early in the 30s, or
some women, but I think what's difficult with hot flashes in the setting of regular, unchanged menses is that you just need to be really objective about like what a hot flash is, and that acknowledge that there are other causes for hot flashes. So if you're someone where you're having hot flashes but nothing else is different, then I think the first thing that I would say to that person is to see your family doctor to evaluate whether it's from something else.
Okay.
Because there's other stuff that can cause hot flashes, really common stuff like thyroid disease, even new onset or worsening anxiety. So you don't want to just all of a sudden say, I'm going through menopause. And having a hot flash when you're 40 doesn't mean that menopause, as I think we've learned, is around the corner. Right. This could be something that's going to go on for a decade. So some people say, am I already going through menopause when I'm having hot flashes? And the truth is that probably not. Probably it's just one of the signs.
So it's really interesting that you're mentioning, don't just associate it necessarily to one thing. Checking with your primary caregiver is really key to making sure there's not other things going on. So what would you tell? What does a proper health, women's health routine look like? Or what would you recommend to women as we are in our 30s? versus 40s versus 50s? Because I'm not sure everyone
knows.
You know, once you've had your children,
yeah,
and you're in that spiral of busyness, what does that look like?
So I'm not a primary care provider, so I am not someone who is doing all this routine screening, and there are different ages at which, and dependent on your personal medical history and your family history, where you would start screening for different diseases like heart disease and cancer, and I don't do that as part of my day-to-day. So I'm just tabling that aspect of the question. But what I will say is that if you're in your late 30s, 40s, and you're noticing changes like disruption in your menses, and it's associated with big changes in sleep, in mood, changes in, you're getting those hot flashes, and you're starting to feel not like yourself. That's what I've had some women come in and tell me, is that like, I feel like I am in somebody else's body, it doesn't feel like me, then I think it's important to talk to your doctor about, could these symptoms be because I'm in perimenopause, and what can we do about them? I think it's tough to put an age, go see your doctor for this exact thing at this age, because I really think it is, I think it should be more individualized.
Right.
Yeah, so that piece of the question is tough.
So in the perimenopause phase, as things are a little bit chaotic, and someone comes to see you, or what are the things that you share with your patients in terms of what can be done in that phase? Because you're not menopausal, you're still fluctuating.
Yeah.
So what do we do in that phase that's can be many years?
Yeah, we definitely can take a little bit of control back.
I like that's myth busting number one.
Yeah.
Myth is, it's out of my control, just live with it.
Yeah.
So,
no, you definitely should not just live with it. And in fact, it's actually less healthy to just live with it in many cases. For example, if you're having chaotic periods that are lasting really long and you're bleeding really heavily, that actually could be a sign of something else that's going wrong, like some sort of abnormal change in the lining of the uterus. What I'm getting at here is a precancerous stage or cancer of the lining of the uterus. What a gynecologist would always do for a woman in her 40s that is having trouble with their periods is sample those cells first to rule out anything abnormal. And I would say 9.9 times out of 10, it will be normal. And then we can focus on getting control of your life from relief of your bleeding symptoms. And often bleeding has to do with pelvic pain. That also will have some association, I think, with their sexual function, which then, ties into their relationship with their partner. And also anemia. A lot of women are walking around with, they don't even know that they're anemic. And even if their hemoglobin is just mildly anemic, healthy women do a really good job of maintaining their blood counts until they're really stressed. So when I see somebody who has even a hemoglobin of 110, which is like 10 points less than what we call normal, I know this person's had really bad bleeding, because it's crazy how much we can bleed and actually have still a normal hemoglobin if we're healthy. So I think we can regain control of those symptoms really easily. Lots of things we can do. We can give, a lot of women don't think they can take a birth control pill in their 40s, a low-dose estrogen and progesterone pill. Certainly lots of women can.
Okay.
Yeah. If you don't love the idea of being on a birth control pill, there are other options, other progesterone-only pills. So I've already told you that perimenopause can be this time of being in real estrogen dominance and hyperestrogenic, so too much estrogen around. So we can sort of balance that out with progesterone, and we can give that orally.
What does progesterone do for our viewers?
Yes, progesterone will balance out that extra estrogen that you're being exposed to by being in these chronic not ovulating cycles, right? So your ovaries are making extra estrogen, you're not getting to that point of ovulating, you're not seeing that rise in progesterone, and what that progesterone's doing is it's actually stopping the lining of the uterus from growing thicker. So, and I left that out earlier, but you do see a suppression in endometrial growth. So endometrium is the lining of the uterus. Yes. And the progesterone will stop those cells from growing. So you can get that as an oral medicine, you can get that as a intrauterine system, which is one of my favorite ways to administer progesterone in a perimenopausal woman.
As in an IUD? Or,
You're absolutely right, as in an IUD. I'm very open with my patients too that I plan to do back-to-back progesterone releasing IUDs until I go through menopause, because I don't want to deal with the chaotic bleeding that will likely ensue in my 40s when I get to that point. So that just releases progesterone at the level of the uterus, and it will counteract that extra estrogen, which telling that lining to grow, it's suppressing that lining. So you get relief of that chaotic bleeding, and as a bonus, you also get birth control if someone doesn't have birth control.
And that's maybe one of the things we may not realize or be conscious of is things are all over the place.
But you can still get
pregnant. An unplanned pregnancy.
You can still get pregnant. Yes, I know. A lot of women are surprised to hear that up until that last menstrual period, which you don't know that that's the case until a year later, you are absolutely still able to get pregnant. Mm-hmm.
Really good.
Yeah.
So what do we have here? We talked about progesterone.
Yeah.
Why is it so important to talk about all these things? I really, obviously we're here because we believe that sharing, and I really appreciate your honesty, even sharing your experience. Like you are a medical doctor, you're trained, you're specialized in gynecology, and you tell your patients what you do for yourself.
I do, because I think a lot of us think, whoa, you're gonna put something foreign up inside my uterus. And we also have a subdermal implant, so it's a little rod that sits underneath your skin and over top of your tricep muscle. They're awesome, and we have all these newly developed tools that weren't available when our moms were going through this.
I didn't know about that.
Yeah.
Imagine who else doesn't know about that. We don't get to see gynecologists very often.
Yeah.
I'd like to remind our viewers, we are in Canada. Every country has its own unique and healthcare system.
Yeah.
But here, the primary caregiver is
the gateway.
Mm-hmm. And so I certainly don't see a gynecologist.
So we are in Canada, and I think one of the things we have to acknowledge too is that in Canada we are unfortunately facing a huge primary care crisis. So I think the stats now are that a growing number, I want to say up to 40%, maybe more, people do not have access to a primary care provider. And that really is the gateway to accessing specialty care. People who don't have a primary care provider are now left to try and access care through other means, and that can be really, really challenging. Walk-in clinics, emergency departments, these are not places where you're necessarily going to be able to access help for perimenopausal symptoms. So people need to know about what changes to look for in themselves and know how to educate and then advocate for themselves on what type of help they need. So I think the first step is just acknowledging, am I in perimenopause and do I want help with these things? So the answer is that there's lots we can do. We have talked a bit about bleeding and the role of how we can help with hormones. There are other ways we can help. Certainly there are procedures we can do. And I usually try not to do surgical procedures unless I've had a failure of medical management with hormones, or there's another reason why that patient would benefit from a surgical procedure.
Okay, so we've talked about bleeding. Let's talk about some of the other symptoms, and maybe bleeding is one. We've talked about hot flashes, so why don't we go to hot flashes? And
hot flashes are huge because a lot of women will experience them and tolerate them. So it takes a lot sometimes for me to sit across from a patient and actually try to advocate and empower them to do something about their hot flashes. A lot of women think that they just have to deal with them. And I have hot flashes, and I wake up every night with night sweats, and I have to change my sheets. But you know what? I'm okay. And I sit across from them and I'm like, are you okay? You're waking up every night? That's the same as when we had newborn babies that we were waking up every night. And it's exhausting. And it's of course going to affect everything else in your life. If you're not sleeping well, it's going to affect your mood. It's going to affect your ability to be productive. And I think all of us, we really try to lead these balanced lives with, eating healthfully and exercising. It's impossible to keep all of that up with compromised sleep. And so I try to educate women that there are really easy things that we can do to help hot flashes. First of all, lots of behavioral things we can do.
Okay.
So, not going to want to really hear this, but certainly
Just tell us.
alcohol.
We want to hear it. Yeah.
Alcohol's a big one. So we're learning now about the new lowering of low-risk drinking guidelines and just the detrimental effects of even what we would consider low-risk drinking in the past. But certainly alcohol can make it worse. And any woman will tell you, I drink wine and yeah, my hot flashes are worse.
Yeah.
Cigarette smoking, 100%. If you can try to reduce or quit, then your hot flashes might actually go away. Achieving healthy weight loss and a healthy body weight is also really important. Not also for other health outcomes, but people who have elevated weight tend to have a worse time with hot flashes.
All right.
And then other things like eating spicy foods that make all of us have hot flashes, even if we're not going through menopause.
Yeah.
And dressing in layers and, just being mindful about those types of things. There's actually some evidence for cognitive behavioral therapy.
Yes, let's go there.
And so I welcome women to try it. There are some resources available online through Sigma, which is a Canadian menopause resource. And so if you can access cognitive behavioral therapy, or even there are some online tools to access cognitive behavioral therapy, then there is some evidence where they employed this with a group of women and they evaluated their hot flashes and they did see an improvement. I have to say that the gold standard is obviously combined estrogen and progesterone therapy.
Yeah.
And so the reason you're experiencing hot flashes is because of a perceived decrease in estrogen. And I know you're going to say, well, wait a second, Jess, you just told me that we're like sky high estrogen in perimenopause. It can vary from month to month. So some months we may be in these estrogen dominant anovulatory cycles where we have predominantly estrogen, and then sometimes we can see that we have a normal ovulatory cycle, and our hormone levels will change month to month. The one thing I talk to family doctors a lot about is that we do not recommend doing blood tests to diagnose menopause.
I see a lot of online forums
I know.
when women who talk about, I had my hormones tested, and maybe more predominant in the US than Canada. I'm not sure. It seems that way, but tell us, why is that not helpful?
It's not helpful because your hormones may look premenopausal 1 month or at one point in the month, and then postmenopausal or just different other months.
Yeah.
And so in Canada, we have a set of recommendations for both family practice and most, I think, all specialties of what are some things that we do as doctors that actually cost money and don't improve health outcomes.
Yes.
And that campaign is called Choosing Wisely. And people may have seen it when they go to the emergency department. More is not necessarily better. Certainly ordering serum gonadotropins, I know it's a big word, but just ordering your serum FSH, LH, and estradiol levels to diagnose menopause or to look into perimenopause is not recommended. It just does not change management, and your absolute levels of hormones really don't make a difference for me. So going to an alternative health provider and paying money to have a lot of blood tests or salivary hormone testing, I won't go there, but no validity in salivary hormone levels and what's functioning in the body and how you feel. But I'm going to treat you based on your hot flashes and what dose of estrogen relieves those hot flashes, and then making sure that if you have a uterus that is going to then see that estrogen that we're giving you for your hot flashes, that we balance that with progesterone.
Protect the uterus.
Make sure that we're not causing an abnormal thickening of the lining of the uterus.
So, should we, since you're opening that door,
can of worms,
the can of worms
of hormone therapy,
therapy, let's just talk about that elephant.
Stay tuned for part 2, where we talk about the controversy around hormone replacement therapy.
There is real invisibility of women, and that is why I'm going to talk about this book today. It's called Invisible Women: Data Bias in a World Designed for Men. It's written by Caroline Criado Perez, And she basically really exposes the fact that if we don't have gender-specific data and focus on male-centric data, we create a world designed for men. The reason I love this book is it's an eye-opener. I didn't realize just how we don't take into account women's real everyday lives. And that then impacts how products are designed, how the workplace is designed, technology, and obviously health. Health is really impacted by the lack of inclusion of gender-specific data. So for anyone who wants to sort of really start challenging that status quo that I keep referring to and see just how much bias exists in our everyday lives. Like there's a chapter where she questions if snow clearing is sexist. She talks about piano designs. We never think about these things, and those are just two examples, but she really breaks it down chapter by chapter with a lot of real world examples that I never even realized impact women, but worse, they marginalize women. So if you want to know a little bit more about that and be aware so that you can demand change, this is the book for you.